Welcome to Chapter 28, Head and Spine Injuries. In this chapter, we're going to review the anatomy and physiology of the brain and the spine, the central nervous system. We'll also talk about assessments of head and spine injuries and treatment plans for patients that have sustained or suspected head and spinal cord injuries. The nervous system's split up into two major parts: the central nervous system, that's represented by the brain and the spinal cord, and then the peripheral nervous system, with those billions of nerves that attach and extend out in our body to allow us for sensation, temperature control that lays within our epidermis, so below our skin. And then there's also nerve endings, motor nerves, that allow for our muscles to move and our body to have function. Here's a diagram showing the central nervous system. You see the brain being the supercomputer at the top that is processing information that it is receiving through the peripheral nervous system. So there's sensory nerve endings in the extremities there that you see. The person is feeling the baseball. And then there's also nerve endings within their muscles and their forearms that can allow them, based off information provided by the brain, of what the brain wants the muscles to do, and then that allows them to manipulate those muscles in a way that you get the action that the brain wants. Another interesting part of this is the reflex loop. So kind of part of our, in a way that we can check is if there's an association between our peripheral nervous system and our central nervous system, is checking somebody's reflex. And so this is the phenomenon that there's a reflex arc that goes from from the spinal cord to the peripheral nervous system. So basically, that's why if you are not paying attention and you kind of put your hand back down on a stove and maybe somebody had a burner on previously and it's hot, your hand will immediately move away from that heat without your brain actually thinking about it. And that's because the sensory nerves sense the heat. It sends that information to the spinal cord in order to send that information up to the brain. But at the same time that that's happening, it's also sending information immediately back to your motor nerves to remove that as kind of self-preservation. So without even thinking about it, you'll remove your hand from the heat. Now you can override this if you wanted to and think about it and put your hand back on the stove and burn it if you'd like. So you can kind of override these reflexes. But your peripheral nervous system has this reflex arc. That's kind of interesting, and that's another reason why physicians, when they're assessing, are checking those reflexes to make sure that your peripheral nervous system is acting appropriately. And then why we also check circulation, sensation, motor function is because we want to make sure that our peripheral nervous system is responding with our central nervous system in coordination. The central nervous system is composed of the brain and the spinal cord. The brain is controlling all the body's functions as well as our center of consciousness. Brain's further divided into three major areas. The cerebrum, which is the largest part of the brain. It's composed of the right, left hemisphere. It performs higher function like interpreting touch, vision, and hearing, as well as speech, reasoning, emotions, learning, and those fine control of movement. The cerebellum is located under the cerebrum. Its function is to coordinate muscle movements, maintain posture, and balance. That's the one that I kind of always remember as the cerebellum is for the balance. When I think of the cerebrum, I kind of think of the conscious thought and personality. And then the brainstem acts as a relay center connecting the cerebrum and the cerebellum to the spinal cord in order to connect it then further to the peripheral nervous system. It performs many automatic functions such as breathing, heart rate, body temperature, wake-sleep cycle, digestion, vomiting, swallowing. And so that's why I usually use the example when the central nervous system's depressed, that you can kind of use alcohol to kind of remember as this progression goes. Someone has a couple drinks, then their cerebrum's going to start to be affected. Their inhibitions will go away, their personality may change a little bit. And then once they depress it further, and they have many more drinks, then their sense of balance, their cerebellum is going to start to be affected. And then if they continue to drink after that point to an extent, they can affect the brainstem. And then a patient may even stop breathing, can't control vomiting, and those things start to happen. So, that's just a representation with alcohol, but the same thing can be said if the central nervous system's depressed for any reason at all, whether it be a traumatic brain injury, any other type of illicit drug use, or even hypoxia of the brain. Anything that's affecting and not allowing the central nervous system to work appropriately is going to be affecting all these areas within the brain, and kind of the progression of that would be affecting the cerebrum, cerebellum, all the way down to the brainstem. So here's a representation of the brain, central nervous system. The cerebrum is going to be the entire, pink side of that brain that you see, what you most commonly think of the brain. And then they've got it further broken down into other areas like the frontal lobe, which, is kind of our personality control center, the parietal lobe for fine motor skills, things like that. And then the occipital lobe right there in the back, that's where our brain is able to take the information from our optic nerve through our eye and process that information and make determinations on what we see, colors, shapes, and things of that nature. And that's why I always say that the window to the brain is through the eyes. So when the eyes because kind of conversely, when there's a problem with the brain, then we can see that representation in the eyes being unequal, or maybe sluggish to react, dilated when they should be constricting, things of that nature. Then below the cerebrum, we have the cerebellum. cerebellum there, kind of on the right, and that's going to remember we talked about your sense of balance. Is where that's controlled, and then further down we'll have the brain stem, which controls basic life function, connected to the spinal cord to connect all of this central nervous system to our peripheral nervous system. And then that location right there, the foramen magnum, that's just the opening, the hole where the spinal cord inserts through. And again, that's the only way in or out, essentially, inside this cranial vault, unless the skull has been compromised itself. Cerebrum controls a wide variety of activities. Most voluntary function, our level of consciousness, our personality, things like that. Cerebellum is our balance, our ability for our body to have movement, and then the brainstem, as we said, is most functions necessary for life. Our breathing, our heart rate, body temperature, things of that nature. Spinal cord is made up of fibers that connect the nerve cells within the brain to our peripheral nervous system. It carries messages between the brain and the spinal cord, be it the gray and white matter, and ultimately connects our central nervous system and our peripheral nervous system. Our brain is protected by the skull. A thick bony structure with the only entrance and exit being that foramen magnum at the base of the skull, inferior right there where the spinal cord is able to connect to the brain. And then on the spinal cord and around the brain, we have meninges. That is a protective covering. Another thing to remember with meninges is that's what is being afflicted when we think of meningitis. Whether it's bacterial, viral, there's an infection within the meninges. It's going to cause inflammation and a lot of pain. Quick rule out for that, we love quick rule outs in pre-hospital, would be to ask the patient to touch their chin to their chest. If they can do that easily without any pain, then I'm going to have a low index of suspicion for meningitis. So in the way that I kind of document as a pertinent negative in a neurological exam, or I usually associate it when I'm just assessing the neck in general. It would be a patient that has a flat, supple neck, flat indicating that they don't have that jugular vein distension, and we talked about that with cardiogenic shock, as well as a trauma to the thoracic, to the or a tension pneumothorax, anything building up pressure there. We may see that jugular vein distension, and the neck being supple describes the patient being able to easily move it. Kind of thinking about trauma for as far as any injury to the spinal cord or the vertebrae, but also for meningitis as well. So when there's actually four different types of bleeds that we think about. We have the epidural bleed, the subdural bleed, the subarachnoid bleed, and the intracranial bleed. Bleed or hemorrhage or hematoma, kind of all describing the same thing. So we'll take a look at the anatomy and we'll further discuss these different bleeds and how they happen. We'll utilize this diagram to better understand the location of the epidural, subdural, subarachnoid, and intracranial bleeds or hemorrhage, and also describe some of them, their signs and symptoms. So first, let's take a look at the different layers. We have the skin, the scalp outermost layer, then to the fascia muscle, and then the skull. And now what we're really concerned about, the first bleed is going to be the epidural bleed that's within the dura mater. Dura mater is just two layers that are actually connected together with an artery that runs in between those. And that is why epidural bleed usually happens rapidly due to trauma. Patient gets hit in the side of the head, so a lateral impact could tear and rupture that that artery and cause bleeding within the dura mater. So epidural hemorrhage, epidural bleed, is going to be a bleed within the dura mater. And then the next layer is the arachnoid space, and it gets arachnoid because of those different kind of spider-like web projections off of it. Well, the subdural bleed, sub meaning below, is actually going to be between that subdura mater and the arachnoid space. So the bleed that's within there, it's actually going to be a venous bleed, often caused by trauma, and it's going to could cause a very slow bleed due to that. It's a venous system. So this may be a fall or a seizure activity that they had a few days ago, and then now you show up and the patient's altered, or something is that activated the 911 system. And another reason why we always need to be thinking about potential trauma causing this altered level of consciousness, because not all traumatic brain injuries happen immediately. The case in point being the subdural hemorrhage is going to be a slower onset. And then below that, we have that arachnoid, and the subarachnoid bleed is going to be just below that arachnoid space, and generally going to be more caused by a stroke, something with a rapid onset. Often the patient will describe it as the worst headache that they've had in their life. So then we got to be kind of thinking potential for that subarachnoid bleed, and then the intracranial bleed going to be within the brain. Now, I know there's a lot to kind of throw at you, but the big kind of takeaways to respect would be the presentation, especially of the epidural bleed and the subdural bleed. The epidural bleed often may present with unresponsiveness, or a patient being unconscious immediately after the impact. Remember, we talked about most commonly that lateral impact. And then due to the fact that it's an artery, the bleed is going to happen very quickly, and they'll go from this unconscious period to what we call a lucid period. So after they become responsive again, they may be awake for several hours, and then after that, after it develops, they're going to go into a coma. So again, having a high index of suspicion and suspecting it based off of the mechanism of the injury and also blood thinning medications that they might be on. And then the subdural bleed, the concern with that, it being a venous type of bleed, this is something that could progress over days. So you got to kind of always suspect that. And then understanding that the subarachnoid bleed is going to be then within that space underneath the arachnoid. Next, cerebral spinal fluid, or CSF. It's produced in a chamber inside the brain. We call that third ventricle. It's essentially going to be a shock absorber to protect the brain and the spinal cord. Good case would be if a patient was in a motor vehicle accident, and then you have that brain slushing around in there. Well, that cerebral spinal fluid can help distribute some of that energy, and so not as much force is applied to the brain. For us, when we are assessing a patient, a good indicator that they have a significant traumatic brain injury would be cerebral spinal fluid draining from any of the orifice of the head, but especially the ears. We commonly see that. Any bleeding or draining from there is going to give us a high index of suspicion that they have a traumatic brain injury, but especially cerebral spinal fluid. That means a lot of force was applied. Remember, we're showing up after the fact, so that's just giving us more evidence to respect the mechanism of injury. In the way that it shows up, the cerebral spinal fluid, when it mixes with blood, it's kind of like oil and water and doesn't like to mix. So if you've ever seen, had a bloody nose and seen droplets of blood, the blood stays together, right? And so you get that kind of perfect red dot when you see a circle of blood. Whereas if it had cerebral spinal fluid mixed with it, since it doesn't like to mix and the cerebral spinal fluid would be around the edge, you would have that maybe that red kind of dot in the center, and then on the outskirts of it, kind of pinkish, water marked out, and not kind of holding that that solid shape that you'd expect just from droplets of blood. You could see this, on the patient's clothing or on gurney sheet or something like that. But that is the significance of cerebral spinal fluid. So kind of understand what it might look like. Again, being pragmatic, any drainage out of any of the orifice, the eyes, nose, or ears is going to be concerning for the traumatic brain injury, but especially if you're suspecting cerebral spinal fluid. We have 31 pairs of spinal nerves, and you should think of the spinal nerves as telephone lines that carry a message back and forth between your body and the spinal cord. They control sensation and movement of your body. And then the 12 pairs of cranial nerves, they transmit information directly to and from the brain. The cranial nerves affect your ability to smell, hear, see, move your face muscles. There's many different dives a little bit deeper into understanding what each cranial nerve does. But essentially, when we do a neurological exam, we want to be checking for all these cranial nerves. And a basic neurological exam will do that. We want to check the eyes, essentially their ability for motor function, moving their face. That's why we have patients smile. Their ability to communicate with their periphery in order to lift their hands and keep them up. So when we do a quick Cincinnati stroke scale, followed with an exam of their eyes and checking their reflexes, things like this, we're hitting a lot of those cranial nerves. Now they'll get a more in-depth neurological exam once they get to the hospital, but we get kind of the most of them with the quickest when we're just checking their eyes, listening to their speech, doing the Cincinnati stroke scale. So here we see a diagram of the central nervous system being the brain and the spinal cord, and then the peripheral nerves that extend out from that spinal cord. Interesting kind of note is that we have the separate hemispheres of the cerebrum, the left and right, and the motor function of the right side of the body is going to be controlled by the left side of the brain. So once it hits that brain stem and the spinal cord right there, it kind of switches. So the left side of the brain controls the right side of the body. Just something kind of interesting to realize when somebody has the essentially loss of motor function on the right side of their body, and then we know that it's going to be the left side of their brain that's affected. There's two types of peripheral nerves. There's the sensory and the motor nerves. The sensory nerves carry only one type of information from the body to the brain via that spinal cord, and then the motor nerves carry that information from the central nervous system to the muscles, so that we're actually able to carry out the activity that our brain wants us to do. But those sensory nerves, they communicate right to that spinal cord. That's where we have that reflex arc that we talked about. The connecting nerves found only in the brain and the spinal cord, they connect sensory and motor nerves with short fibers. They allow the exchange for simple messages. Again, this is that reflex arc. That connection is the reason why we're able to have a sensation of heat, and our peripheral nervous system is able to carry out and act without involving our central nervous system, that reflex arc. How do nerve systems work? Controls virtually all of body's activities, including reflex activities, a reflex arc, the voluntary activities consciously performed, us overriding that reflex arc. I don't care if that stove's hot and pushing your hand on it, as well as the involuntary activities, the ability to for digestion, for us to breathe, which breathing is kind of interesting because the muscles of our diaphragm and our intercostal muscles work both on voluntary and involuntary. So if we don't think about it, if we're not trying to control it, then it's going to be regulated on its own, but we can override that, decide to take a deep breath, decide to hold our breath. So here I guess got a little bit ahead of the slides, but we already discussed the reflex arc. They connect the nerves in the spinal cord. From the reflex arc, if a sensory nerve detects irritating stimulus, bypasses the brain and directly to that the motor nerves and allows you to remove the hand. So we have the somatic or the voluntary nervous system, all voluntary actions. When we think of our musculoskeletal system, to be able to move our body and voluntarily go and pick up that glass, that's where we're going off our somatic. And then the autonomic or the involuntary nervous system is further broken down into two separate functions. We have the sympathetic and the parasympathetic. When you think of sympathetic, it directs the body's rapid involuntary response to dangerous or stressful situations. So if you see, a shadow over there kind of spooks you out, you're going to have this autonomic involuntary response, and you're going to have a flash flood of hormones that'll boost your body's alertness, your heart rate. It'll send extra blood to your muscles in order for you to perform work and get you out of that situation. Now, realize that our body likes homeostasis, right? Everything to be kind of back on the level. So if the sympathetic nervous system is able to boost it and bring it back up, then our parasympathetic nervous system will bring it back down, can help slow our heart rate down and bring us back down to that level homeostasis that our body likes to function, to stay at. Because if we were jacked up sympathetic nervous system all the time and weren't able to bring it back down, that would cause another myriad of problems, because muscles, heart, all these things can't perform work for an extended period of time. So it's kind of that short acting. When we think of sympathetic nervous system, think of short, fight or flight, and it's a shorter word. And then the parasympathetic nervous system, parasympathetic is a longer word, so these are help bring us back down and also kind of helps regulate hormones for longer acting response. I like to think of this as the feed and breed, so your digestion and to help with things that take a longer time. Now the skull. Skull is composed of many bones. First we'll talk about the cranium, or the top part there. It can even be further broken down into different regions. These are kind of named after the brain underneath as well. So where all those suture marks are, that's essentially where these different portions of the cranium are. You have the frontal region and the parietal region on the side there that the line is indicating to. Below that, the temporal, and then the back occipital. We also have bones in the nose, the nasal bone, the zygomatic bone right below your eye there that makes up essentially your eye socket. And then the maxilla and mandible are the different structures of your jaw. Maxilla on top, it's max, it's on top, it's the best, and then mandible being that lower portion of the jaw that's able to move. And when we're trying to open up somebody's airway, be it the head tilt, chin lift with, or especially with the jaw thrust maneuver, then when we're trying to align that to make the airway so that it's easier for air to move in and out of it, because we get it more in line, but also we're trying to lift that mandible up, because adhered to the kind of base back of that right there is where your tongue is affixed to. So if we lift up that mandible, then we're going to open up the airway much better. This shows you the different regions of the cranium, the occiput, which is the back portion. So if someone were to fall backwards, they'd most likely land on that region. The temples is on the lateral side, bilaterally there. And remember that we talked about a good indication of an epidural bleed would be that lateral impact. So if come in contact with the temples, if you're able to easily describe this, pass this information along, may help them get to better understanding what's going on for the patient in that exam once they get to the physician. The parietal region would be that very top superior portion, with the frontal region being anterior or your forehead there. Face composed of 14 bones. Some of the major ones, the maxilla, remember max on top, of your jaw, so your top teeth there, that portion, the bones that connect those into your face. The zygoma or zygomatic bone would be that bottom portion of your eye socket, the mandible portion of your jaw that's able to move, that we manipulate in order to open up an airway. The bones of the nose or nasal bones, and then various other frontal bones that will make up your face. Spinal column, body's central supporting structure. There's 33 vertebrae divided into 5 sections. Vertebrae are connected by ligaments and separated by cushions called intervertebral discs. You may have heard if someone has a slipped disc. It's usually, over time, just gravity pushing down on our spine, compressing it. That's why the older you get, the shorter you get. And this cushion starts to deteriorate, and those slipped discs can even pinch nerves and cause chronic back pain. The spinal column is almost entirely surrounded by muscles that help support it and allow it to move and allow you to be able to manipulate your entire body surrounding the spinal column, which gives your supporting structure through your entire body. This diagram shows the different regions of the vertebrae. We have the cervical, or we commonly think of just the neck. Thoracic, where we'd see the rib cage adhered to part of it, and then the lower back or the lumbar, and then the sacrum down to the coccyx, those bones that are fused together that make up the tailbone. We do need to memorize these numbers, how many vertebrae are within each region. Since I love food, I always associate things with food, and I think of meal times. So cervical, we have breakfast at 7, thoracic, lunchtime at 12, dinner, lumbar's 5, and then I always eat dinner again, have seconds, so another 5, and then just remember those 4 fused bones of the coccyx. So depending on where directly within and encased in the vertebrae is the spinal cord. So when we have a spinal cord injury that's suspected, when we see maybe the patient doesn't have a feeling, or they're paralyzed at their lower extremities, it all depends on where along this pathway or which region that there is has been compromised. So generally speaking, the higher up you go, the worse off the injury is going to be, because wherever the line is of that spinal cord injury, everything below that oftentimes will be paralyzed. And then when we get up to the neck, we also have more concerning. If we go through C3 to C5 in that area, so kind of more of the base of the neck, but kind of midway through there, if we have an injury at that location, that'll actually take out your ability for your body to control your diaphragm, so the patient won't be able to breathe unless you breathe for them. And then C1, C2 at the superior aspect of the neck, right where it connects to the skull there, there's also major blood vessels that run through there, so a very ominous diagnosis. So we're going to mark and track and feel all the way down each vertebrae, looking for step off, which just means essentially a bigger separation between the 2 vertebrae that you'd expect as you march down. Oh, there's a bigger jump as I go from one vertebrae to the other, or something is shifted to the side, so it's deviated off to the side, one side, another indication that it has been compromised. And again, it may have broken the vertebrae or displaced the vertebrae, but not affected the spinal cord. So these are the patients where it's that much more important that we are able to package them appropriately in full C-spine to prevent that, essentially, from us causing further damage to their spinal cord while we're moving the patient. Another thing to kind of along those lines, because we're going to reevaluate circulation, sensation, and motor function, um, before and after when we're going to secure somebody in full C-spine, and also as we reassess. And a reason why we do this, let's say the patient can't feel anything in their legs, and then it kind of feels like insult to injury to ask them again, to be asking them about it, kind of bringing this up. And also something that you can inform the patient for hope, and to kind of keep them in hopefully more of a positive light as you go through, is there may just have been a spinal shock essentially, and they didn't sever or damage their spinal cord, but due to that shock of the spinal cord, the force that was applied to it, they may become paralyzed or lose sensation in their body, but that may not be a permanent thing, right? So just kind of food for thought as you're assessing somebody and going through, you kind of want to be prepared for everything, and why you do still want to be reassessing that, because it may change. But again, remember the numbers: 7, 12, 5, 5, and 4, breakfast, lunch, dinner, fused coccyx. Now we'll talk about head injuries. A traumatic insult or a traumatic brain injury, TBI, may result in the soft tissue, the bony structures, or the brain itself. The brain injuries account for more than half of all traumatic deaths. So this is why when we talk about that patient that wasn't wearing a seatbelt and their head went through the windshield, essentially descalped them, very bloody, very vasculature on the scalp, significant bleeding. You as a trained EMT are aware that that is not my biggest concern. My biggest concern is within what's going on inside the brain. So really evaluating their eyes, their circulation, sensation, and motor function, getting them in full C-spine, and getting them transported rapidly, right? It's not the scalp injuries that I'm concerned about. Those are secondary injuries. The primary injury that I'm concerned about would be that traumatic brain injury. Fatal injuries invariably involve the brain. The other one that happens quite a bit, and the problem is due to either geriatric patient, older age, or alcoholism or chronic alcohol use, will atrophy the brain. The brain is a muscle, and if it atrophies, it means it's getting smaller, and so there's more room within that skull for that brain to move around. So to bring it back to the collisions within a automobile accident, we can prevent that first collision, or limit its effect by making a vehicle crumple, but by the way that we design them. That second collision, we have the seatbelt laws that we do, and people are doing better at following those kind of culturally nowadays. But that third one, we still have that rapid deceleration when the force is absorbed, and your brain has that coup contre coup, slushes back and forth, and it's somewhat protected by the cerebral spinal fluid. Again, significant that they had a traumatic injury would be if you see that cerebral spinal fluid coming out, or any drainage coming out. But this may be why you have a motor vehicle accident where one patient was dead on arrival because they had that atrophy in the brain, and because they had that traumatic brain injury. So be alert and really think about that mechanism of injury, and have a high index of suspicion for traumatic brain injuries. So we have two different types of head injuries. We have closed injuries and open injuries. Super easy to differentiate, right? One's closed, one's open. It's not more complicated than that. In a closed injury, the brain has been injured, but there's no opening into the brain, right? There's the skull hasn't been cracked. Now, with a closed injury, the concern would be that buildup of that intracranial pressure. And then an open injury, often caused by a penetrating trauma, may be bleeding, exposed, and you may see that brain tissue. But again, you're not going to have that buildup of intracranial pressure, but then you have that other myriad of problems that stem from infection. So we're going to want to make sure that we're keeping that area clean, covered as best as possible. Motor vehicle crashes are the most common mechanism of injury for a traumatic brain injury, and just based off of how physics works and that how energy is dispersed, but also just because of how many people are driving all the time, just a huge number. Other common mechanisms would include assault, falls, or even sports related injuries. We have to have this index of suspicion for that traumatic brain injury, because a lot of them are going to be closed head injuries that you're not going to be able to see. So you need to look for signs and symptoms, altered level of consciousness, and we need to evaluate the eyes, circulation, sensation, and motor function, so we can check to see how the central nervous system is, if it is in communication with the peripheral nervous system, and then overall anything else, have a high index of suspicion based off the mechanism of injury. What force was applied to the body, where was it applied, and have that kind of be your guide, even if you don't, in the absence of any other signs and symptoms. Here's a list of general signs and symptoms of head injuries, not listed in any particular order. First, we definitely have decap BTLS, right? Deformities, contusions, abrasions, punctures, lacerations, tenderness, swelling. Then we also have soft area of the skull or depression. Be aware too if for infants that still have the fontanelle or soft spot on the top of their skull, one sign of intracranial pressure could be a bulge in that spot. Kind of also a sign of dehydration could be indentation in the soft spot there. We'll go over that a little bit more when we talk about pediatrics. Any visible fractures of the skull or the face, because recognize we see this damage or fracture to the face. More concerning about that fracture is the force that was able to break that bone. That force was also applied to the brain. Irregular breathing pattern, also with slow heart rate and hypertension. Remember, that's that Cushing's triad of the essentially Cheyne-Stokes respirations. Period of apnea, and then it'll pick up again. Also the bradycardia, hypertension, as well as the widening pulse pressures. We have the narrowing pulse pressures that makes us suspect internal bleeding. Widening pulse pressures. When we talk about pulse pressures, we're talking about the systolic and the diastolic. So a widening in those, we're going to start to be suspect of that intracranial pressure, because the systolic pressure has to raise up so that it can counteract the pressure within the skull and still perfuse the brain. Ecchymosis or bruising about the eyes, we call those raccoon eyes, or battle signs just behind the ear on the mastoid process. You're going to see some ecchymosis, also called bruising there. Those signs all come up late though, so be aware that's going to be something. Anytime when we think of bruising as a sign, we may not see it initially. It takes some time for that to build up. Clear or pink CSF leakage from the scalp wound. We talked about it before, as it would show up as, kind of a red blot, and then a pinkish on the outside halo type of effect. The cerebral spinal fluid itself is clear, so when I was describing it before, that's when it's mixed in with the presence of blood, which you would expect with a traumatic injury, but even just that clear fluid or pink, and then also that halo effect with blood is going to be indicative of that cerebral spinal fluid, and definitely be concerned about traumatic brain injury. Failures of the pupils to react to light. So from what we know about pupils, what happens when you shine a light into a pupil? That's right, it should constrict, right? The lens of your eye essentially will open up or dilate to let more light in, so that your optic nerve can perceive and send that information to your occipital region of your brain to process, and then the lens will constrict or become smaller in the presence of more light, so it doesn't damage that optic nerve. So if that's not acting appropriately, then we're thinking of a head injury. Another cause would be anything that depresses your central nervous system. So drugs can also have that effect on it as well. Unequal pupil size. Anything with the eyes not being purple, pupils equal, round, and reactive to light. is concerning, and we should have a higher index of suspicion for potential head injury. Loss of sensation or motor function. So we'll find this out when we check the circulation, sensation, motor function in each extremity. Any period of unconsciousness is concerning. If they don't remember the event, did you lose consciousness? Did you remember the event? What happened? This is the type of kind of line of questioning that you should have. Now you're probably starting to gather when we do that history taking, it's not just to sample an OPQRST. We need to ask some practical questions. And if you don't get an answer that makes sense to you, try to ask again or in a different way. Amnesia, whether it's retrograde amnesia, not remembering anything after the event, or anterior grade amnesia. I think I got those mixed up. It would be retrograde amnesia if you don't remember the event or things after, or anterior grade amnesia when you don't remember anything after the event or not making new memories. Oftentimes we see this with a concussed patient that we suspect having a concussion. You may give them a simple phrase to remember. Hey, this may sound silly, but I want you to remember the phrase 12 bananas in a tree. And have them repeat it back to you so that that their brain is processing it. Okay, 12 bananas in a tree, and then come back later to them in 5 minutes when you reassess and see if they are able to produce that information. So again, this isn't orientation questions as far as person, place, time, and event, but this is try to see if they can retain new information. So just different ways of assessing their neurological function. Seizures is another potential indication of a head injury. During their seizure, you want to make sure that they can't injure themselves further, and you just stand by and monitor. Hopefully you'll have a pulse ox on them. The concern with seizures partly is that they're not going to be able to protect their airway, but usually they ventilate okay, and then just how long has the seizure sustained. So try to, as you're taking care of the patient, understand how long that the seizure has been, how long it lasted, and did they regain consciousness after that postictal period is important to pass on to higher level providers. Numbness or tingling in the extremities. This is a huge one because I oftentimes have been on calls where a patient, that will be their only complaint after a ground level mechanical fall. But if patient is elderly, has other comorbidities, this is an indication of a neurological deficit. So that would be a patient that we would probably be considering more likely to put them in at least spinal motion restriction, if not full C-spine, after a traumatic event. Irregular respirations, that kind of goes with that irregular breathing pattern that we discussed earlier. Any dizziness, visual complaints, whether it be photophobia, which the light bothers them, diplopia, which is seeing double vision. Any disturbance with their vision is concerning. Remember, eyes are the window to the brain. Combative or abnormal behavior. This is the kind of nightmare patient when I work on the ground units as a provider, because we are not allowed to RSI, so essentially sedate that patient, take over their airway, put them on a ventilator, and get them where they need to go. So resource-wise and management, you need to kind of understand and, again, visualize this combative patient through the eyes of what was their mechanism, right? Were they thrown from a motorcycle and now they're being combative? Don't just chalk it up to, hey, this guy might be kind of an asshole. You need to give essentially them the best chance and be an advocate for them, and that may be having to restrain them in order to get them to that help that they need due to the potential traumatic brain injury that they have. Nausea, vomiting, again, this is one that we see with a myriad of afflictions to the human body and their response to it. But nausea and vomiting is concerning, and we want to be prepared for that as well, especially if you have a patient that's secured onto a backboard. What is that going to look like? Or if they start to vomit while you're applying them to the backboard, right? We need to be prepared for the situation. If the person at the head needs to control it, or you need to talk to them and say, okay, we'll move them over because you're going to need to get them on their side so that they can drain from the mouth and not potentially get that vomit in their lungs or aspirate on it, which could cause an aspiration pneumonia, which could cause them problem down the line. So it needs to be a coordinated move in order to get them onto their side safely, because again, this could be a patient that we're very concerned about having a spinal cord injury on as well. Posturing. So this is the part of the GCS, Glasgow Coma Scale, under remember there's 3 different sections. You got your best eye response, which we have kind of solid down now from AVPU: alert, verbal, painful, or unresponsive. And then we have the verbal response, which would be that they're orientated, right? Person, place, time, and event, or they're confused, or they're using inappropriate words, incomprehensible sounds, and then down to verbally unresponsive. And then for the best motor function, we have able to follow commands, and then a step down from that is that they're able to localize pain, then they're withdrawing from pain, and then we get to these 2 posturings that would give them either 3 points, 2 points, and then 1 point being unresponsive. So we have the decorticate posturing, and when I think of decorticate, think of the core, right? So the body's still, if we're looking at it as how obtunded or how affected is this brain in this situation. Decorticate, it's still kind of trying to protect itself. So you're going to see the patient posturing or essentially flexing all its muscles towards its core. And then a step down from that would be the decerebate posturing, where they have all of their muscles fully extended out. And don't, confuse that with unresponsive. It's one of those, like, when you see it, you'll know. And it's also a really good indication of you got to get moving when you see this decorticate, decerebate posturing. You need to do it safely, but that's a patient where the minutes and seconds that you spend on scene are really going to make a difference. Scalp lacerations can be minor or serious. Big dependent on those is going to be if they're on blood thinning medications, right? Any trauma, injury, altered level of consciousness, especially if you're talking about a geriatric patient, should instantly go to, is there any known blood thinners that they're taking? Small lacerations can lead to significant blood loss, and this says especially in children, which they're very vascular, which is true. But I also want to think about this with you, to think about it with the geriatric patient. You may be there for something completely different, and also that backbone of that subdural bleed, that bleed that takes a lot longer. So their presentation may have came out something medical or altered, or when really, have they fallen recently? Look for other evidence of it, a history of falling, right? That's that index of suspicion, so that you're putting these together so that you're a good advocate for your patient and figuring out the best place for them to go, and to have that sense of urgency to get off scene. Is this need to be done now? No? Okay, let's go, and then we'll take care of everything we can en route. Again, skull fractures may be open or closed, just depending on whether there's that opening of the skin. Open generally from a puncture injury, closed usually due to the blunt force trauma, which is more concerning because it's harder to tell what's going on underneath there, and we may not see this bruising until much later on. Their head may be deformed, you may visually see some cracks, you may just feel, when you palpate, you feel crepitus, kind of bone crunching. That's another sign of an underlying injury. Recognize bruising, or the raccoon eyes, battle signs. Those are going to be later signs, kind of indicative of a trauma that happened at least an hour or a few hours ago. This is a good representation of the raccoon eyes and the battle signs. We have different types of skull fractures. The linear skull fracture would be most, about 80% of skull fractures. We're going to need a radiograph required to diagnose linear skull fractures, because there's often no physical sign that we can see on the outside. It's just there on the skull, and we don't have x-ray vision. So again, we are going to suspect this due to the mechanism of injury, or altered level of consciousness, pain, that crepitus that we feel, or potentially changes in their eyes. Depressed skull fracture is result of a high energy trauma. If it's able to depress that skull, the cranium is very, very hard. So if there's a depression in it, significant amount of force was applied to the brain, and highly suspecting of a traumatic brain injury. There may also be bone fragments that are driven into the brain, resulting in injury. So these type of patients, you need to have a quick response and get them to that definitive care, level 2 trauma center, because they're going to need surgery. Their definitive care is going to be neurosurgery. Basilar skull fractures is associated with high energy trauma. Signs include that CSF draining from the ears, raccoon eyes, battle signs, any of these basal skull fractures right there at the base of the skull. Also concerned with a basal skull fracture, a definite contraindication would be using an NPA, nasal pharyngeal airway. Now, I know I've talked before about the nightmare of it is concerning if you have that false pathway and actually go through that basal skull fracture into the cranial vault, and then you could imagine even one ventilation or any air that gets pushed through that NPA. Yeah, that's right. It's going to go right into that cranial vault and cause a whole myriad of problems. But it's kind of difficult because we can't see the basal skull fracture, so we oftentimes go off of the mechanism, right? Any blunt force trauma to the face is a relative contraindication to an NPA. And I say relative because, you got to use some provider judgment here. If they got hit in the face with a baseball bat, yeah, that's significant. We're definitely going to try to avoid at all costs utilizing an NPA. But if they were, they fell off a swing and it was witnessed, and maybe when they hit the ground, they bit their tongue. And kind of based off of that, you may not be as concerned to utilize an NPA, and it may be appropriate because of essentially the bleeding that's going on inside the mouth, right? And that might not be your best airway option as opposed to the nasal route. So just kind of be aware of that, and the kind of spirit of the rule versus a hard, fast rule, which is really awesome. In regards to being an EMT, but also difficult, is we have these protocols that we follow, but people and patients don't follow cleanly into these protocols. So a lot of times we need to understand what's going on, right? The pathophysiology, what's going on in the body, to make the decision on what we're going to do, right? Traumatic brain injuries, most serious of all head injuries. There's two broad categories, direct or indirect. Primary brain injury results from instantaneously from impact to the head. The secondary brain injury is the severity increases with the severity of the primary injury, but it's that intracranial pressure, the buildup of it, the bleeding that happens as a result of that primary injury. So you have that first initial impact, but then as the body's doing what it's trying to do to either heal that portion, or if it caused damage in that primary impact, you're going to have a secondary result that may continue to get worse. So this is why reevaluation is so important, and we're going to want to continuously monitor and evaluate patients that we're concerned about traumatic brain injuries. Now, what does that really mean, right? We're going to be checking vitals on them, every 5 minutes, but also talk to them, carry on a conversation. Because if you're too stuck up in, what you're doing and not thinking big picture, and you're not communicating with that patient early and consistently, you may not notice when they start to have a decrease in their level of consciousness, when they start to get more confused. And this is not just important for us to recognize that so we know what to expect in the time that we're with that patient, but these are important time and chronological events that will affect their treatment when they get to that definitive care. And it may not be at Banner Lassen with the ER doc. It may not be until they get transferred again to neurosurgery, and the neurosurgeon is going to want to know this information. At what point in time were these changes did they happen? So it's important that we pass this information along and that we document it well and clearly. Secondary injury may be caused by the hypoxia, hypotension, the cerebral edema, the intracranial hemorrhage that we spoke of before, that increased intracranial pressure that's happening, cerebral ischemia, remember ischemia, lack of oxygen, or again, infection. That's why we're trying to keep the patient as aseptic and as clean as possible. They can result from blunt or penetrating trauma. The coupe contra coupe injury, that's that slushing around in the brain that I was talking about before, when a patient has that third collision in a motor vehicle accident and they come to that rapid deceleration as their car hits a tree. It's not just going to be their head or their brain coming in contact with that frontal region. It's going to then slide backwards again once it comes in contact with that and hit the occiput, and then might slide back again, right? It's that movement inside the cranial vault. And it's increased by atrophy of the brain caused by the patient being elderly or chronic alcohol use. Head falling back against headrest injures rear part of the brain. So when we talk about the different collisions and impacts and understanding what that mechanism is, then we can suspect where these potential injuries may result from. And again, this might not be as important to us as we're maintaining the ABCs, airway, breathing, circulation, and we're transporting them safely and quickly to that definitive care. But we're the ones that are on scene that got to see this, so we have to get that good story. When we talk about a trauma assessment and on scene, that time before, let's load and go, right? Let's get out of here, because we understand best treatment, sometimes diesel, getting them to that higher level of care as quick as possible. But realize once you leave the scene, you may be that only connection within the physicians and the staff at the hospital to communicate to them what that mechanism was. What did it look like? What did you see? So you got to make sure you have a good understanding. And this can be easier said than done when you have a patient that's crumping or decompensating on you, and you got this sense of urgency, like, I got to go. This is where the assessment is so important, to delegate things out, right? If they have some significant bleeding and you have a partner there, they can handle that, right? Put direct pressure on that. If the bleeding doesn't stop with that, go right to a tourniquet. As you're trying to get story from either a bystander or somebody that saw it, or saw the damage pattern on the vehicle, just make sure that you run it through your head before you leave scene what happened, right? That you have the story. Cerebral edema is swelling of the brain. Edema, right, is fluid, cerebral, talking about the brain, and it may not develop for several hours following the initial injury. That's why we have that, again, a good representation of the primary and secondary injury would be when we see that epidural bleed, right? Initially, we have that unresponsive loss of consciousness because of that side impact. It lacerated an artery within the dura mater, so it's that epidural bleed in there, and they become unresponsive. And then when they come back, they're kind of lucid, but they're still with it. They're able to talk to you, but you're getting that secondary injury that's developing with that bleeding, that intracranial pressure, that cerebral edema. Edema doesn't mean, water, blood. It doesn't specify. It's just fluid that's inside of there, right? Because we have a lot of fluid. We have the cerebral spinal fluid. We have the potential blood that's also mixing in with that pressure. and kind of something to understand why that blood pressure, the systolic, is rising so high. Essentially, you have to take the cerebral spinal fluid, so in the brain, the pressure that's already in there, and then take their intracranial pressure, the pressure that's building up, and then you minus that pressure away from their systolic blood pressure, and that's what's actually getting and perfusing past that point. And again, this is more conceptualized, but to understand, hey, when you see that rising blood pressure, this is what's happening. It's trying to counteract that cerebral edema, that intracranial pressure. We talked about intracranial pressure and that buildup, and how the systolic blood pressure has to rise in order to combat that, to still perfuse for cerebral perfusion. But also another concept is wherever that buildup or pressure is, it's going to push or displace the brain away, and that's going to be causing a myriad of neurological deficits that we see. And also, if that pressure builds up too much, there's only one way in, one way out if we're talking about a closed head injury, and that's through that forearm magnum, and that's where we get that brain herniation and where you get those true posturing going. If you want to understand kind of what's happening, how severe is that the decorticate or decerebrate posturing, we're starting to think they're on this track of herniating their brain, and very time critical. Signs of intracranial pressure, it would be the abnormal respiratory pattern. We talked about Cheyne-Stokes respirations, any unusual patterns. One thing to recognize where this is a little different with kids, don't confuse crying with an abnormal breathing pattern. When kids get they kind of get that worked up and then they start crying again. That's a lot different than that breathing pattern, the Cheyne-Stokes with the bigger volume and the apnea. Crying in kids is good. At home, I don't like crying so much, but in my ambulance or in the hospital, it tells me they got an open airway and they're breathing well enough to cry. The kids that are concerning are the flaccid kids, no muscle tone, very sleepy, tired kids. Decreased pulse rate, so bradycardia, headache, nausea, vomiting, decreased alertness or altered level of consciousness. Decreased pulse rate and bradycardia is the same. Sluggish or non-reactive pupils. Understand that they may also be indicative of illicit drug use, decerebrate posturing, and increased or widening pulse pressures. And then the Cushing's reflex. And Cushing's reflex is just another way to describe the Cushing's triad. When they go into Cushing's reflex, they have that hypertension, they have that bradycardia. Oftentimes you'll get that irregular breathing pattern in Cushing's triad. So the epidural hematoma, the accumulation of blood between the skull and the dura mater, nearly always the result of a blow to the head produced by a linear fracture or a thin temporal bone. So the signs and symptoms would be as we're either the mechanism of that side impact, or we see a fracture line, or we feel crepitus, or there's pain on palpation on that side there. You're going to have that hematoma between the dura mater and the skull. Subdural hematoma is the blood underneath the dura mater, but outside the brain, outside that subarachnoid space. Occurs after falls with a strong deceleration. We see this in motor vehicle accidents often. Intracranial hematoma, bleeding within the brain itself. It can be following penetrating injury to the head because of the rapid deceleration of forces. Subarachnoid hemorrhage. Bleeding occurs in the subarachnoid space where the CSF circulates, results in bloody CSF and signs of meningeal irritation. Remember, the meninges surround that central nervous system. Common cause include trauma or rupture of an aneurysm. And just kind of a side note for the epidural and subdural bleed, you can see these on a CT scan. You won't see that subarachnoid bleed on a CT scan. They'll do something called a lumbar puncture. Well, they'll actually take a sample, what normally they would get just cerebral spinal fluid out. Now they're going to have that blood because of that hemorrhage in the subarachnoid space mixed with that cerebral spinal fluid. And that essentially is how they diagnose that type of hemorrhage. Concussion. A blow to the head or face may cause a concussion of the brain. It's considered a mild traumatic brain injury if you think of it as the spectrum. There's a temporary loss or alteration of part or all of the brain's ability to function without physical damage to the brain. So the concussion is leaving just this temporary neurological deficits. Oftentimes they'll have that anterior grade amnesia. It's going to be difficult for them to recall maybe the event and things after the event. About 90% of patients do not experience a loss of consciousness, so that's not always the telltale sign of a traumatic brain injury, that loss of consciousness, that primary injury, but it could just be this that they have this concussion, which is considered a mild TBI, and they should be evaluated by a physician. A patient may be confused, have amnesia that we spoke about, usually lasts only a short time. Assume that the patient with signs or symptoms of a concussion has more serious injury until proven otherwise. That's that we get paid to overreact, right? Oh, this is just a concussion. You are doing standby at a football game or something's going on. This could be, you could be right, but if you're wrong, that risk versus gain. So they should be evaluated by a physician. Contusion. It's more serious than a concussion. There's actual physical injury to the brain, right? So the concussion, there's no physical damage to the brain, no bruising, but a contusion, there's actually bleeding that's happening. Maybe sustained, long-lasting, even permanent damage. A patient may exhibit any or all of the signs of a brain injury. And again, it's hard to tell. How do you know just from looking at them, oh, that's just a concussion, right? You just need to walk it off. Try not to sleep, or all the things that we used to kind of see around concussion, misinformation. We need to treat these seriously because we're concerned that there could be that contusion, that permanent lasting effects from this, that quality of life issue. We have to be their advocate and speak on behalf of the patient's best interest and make sure that they get appropriately evaluated. Now, this kind of brings me to a case in point of you don't always need to transport the patient via ambulance to be their best advocate, right? There's no point in, getting fighting with a patient, or maybe if we're talking in this instance at a sporting event with a parent on, they need to go by ambulance. It could be all of these things. We have to have that word judo and realize all that we really want is for them to get evaluated. Obviously, we want them to be done safely and would love to be able to monitor them and help them and guarantee that they get there. But start thinking outside the box potentially. I understand that it can be an expensive bill for an ambulance. And as long as they're getting evaluated, oftentimes, in these instances, I'll be okay with that. I've even, had them sign in against medical advice because that's what they're doing. They're going against my advice that they be treated and transported in my ambulance to the hospital, but they're still willing to go and tell them, hey, I'll follow you behind and make sure that you get up to the hospital, and if there's an issue, you can pull over and we can kind of take over there, because I just want to advocate for that patient and have them be evaluated by a physician. Other brain injuries can arise from medical conditions, blood clots, hemorrhages. We're thinking of stroke, right? Cerebral vascular accidents. Signs and symptoms often are the same of those traumatic brain injuries. So the severity and the way that we think about a stroke, right? Stroke time critical. The mortality rate is high. The quality of life, all of those issues. Same type of sense of urgency with a traumatic brain injury. Spine injuries. Compression injuries can result from a fall. Forces that compress the patient's vertebrae vertebral body can cause herniation of those discs. They can slip aside. They can become structurally unsound, and during transport movement, they could essentially cause damage to that spinal cord. So, this is again where you have to be careful. Look at the mechanism. That's what we do in our scene size up before we even get to that patient, so that when we see the patient that came out of that vehicle that was suspected going, that speed, and they're pacing up and down the road, we need to get over there and have them limit, and stop essentially manipulating and moving their neck around. Take control of that. Have somebody be married to the head. Since they're self-extricated, at the very least, have them spinal motion restriction, meaning having a C-collar in place versus potentially having them in full C-spine on a backboard. At the very least, right? Spinal motion restriction. Motor vehicle crashes can overextend the spine. They can have it stretch out, right? There can also be that rotation flexion injuries of the spine of that rapid deceleration forces. So our spine that we talked about is surrounded by clusters of muscles to allow us to have good movement, flexation in each direction, and be able to manipulate. But that ability to move can also get strained very quickly if it became out of, if it gets pushed to its limit due to excessive forces, oftentimes with motor vehicle accidents. When the spine is pulled along its length or hyperextension, it can cause fracture, like a strangulation or an extension of that spine. Any one of these unnatural motions results in fracture or a neurological deficit. Many bones of the spine are altered from traumatic forces. They can fracture or move out of place. Again, that's why we need to advocate for them and put them in full C-spine if based off their mechanism, plus if we see any changes on our physical exam, and take these patients very seriously, because they're not complaining. They can feel their extremities move them around. Maybe they got a little sense of tingling, and it hurts when you push right there on the spine. And believe me, it's not going to be comfortable for them on a backboard, because if you think about what happens when you have a isolated injury or injury right there in that location, there's bleeding, there's swelling, things that result, and then you put them on a flat backboard, and they're going to have all that pressure right on that portion. But it's kind of the risk versus gain that could cause some pain and some localized increase in being uncomfortable. But what we want to do is make sure that they don't manipulate their spine at all and potentially sever their spine when originally they only had a break in their vertebrae or instability in that spinal column. The patient assessment. Always suspect possible head or spinal injury with any of the mechanisms that you would think there was a lot of force applied to that spine, right? Motor vehicle accidents, pedestrian versus motor vehicle, fall, even a ground level mechanical fall. Someone's just standing upright, they trip and they fall. Elderly patients may have osteoporosis. They may have less bone density, more likely to have a significant fracture. And I've had this same type of patient. She stepped off a curb and she tripped stepping off the curb, and she fell and she hit her face and tried to catch herself with her arm, but missed, and she was only complaining of shoulder pain. And what kind of led me down the right path was she actually blew out her eye. And it was, I saw some bleeding and hematoma happening inside of her eyeball, and there was a little laceration on it, and she wasn't complaining of any pain there. So that's an easy distracting injury. Put her in C-spine and took her to the hospital, and a few days later went back and on following up, that continue quality improvement, CQI, we should constantly be following up and kind of learning from our experience. She actually had a cervical spinal fracture, right? She didn't sever the cord or anything, but if we would have essentially we could have made things much worse in how we packaged her and how we moved her. So that was a good eye-opening for me. Any penetrating trauma to the head, neck, or back, or torso. And for this one too, I definitely call it relative as far as how close to the midline is this penetrating trauma? Because it does take some time placing a patient in full C-spine. And if somebody is on like the lateral flank, has a penetrating trauma with a knife wound and there's significant bleeding, the best thing may be a scoop and run on that patient. Now, if it was more medial onto the spine or any neurological deficits, then it may be appropriate to be working on stopping that bleeding as you're packaging them and then a rapid transport. Other common mechanisms of injury would be that rapid deceleration injury, hangings, axle loading injuries, or diving accidents where you have that pressure that's pushed along the long axis, but too much force is applied and causes an injury that way. As always, we're going to practice good scene safety, evaluate the scene for hazards, use our standard precautions, body substance isolation, wearing gloves. We need to look at the indicators for the mechanism of injury. So when we're in a vehicle, we're looking at damage patterns, right? Is there spidering of the windshield? Indicative you'd be suspecting of the head injury, spinal cord injury. Is there a bent steering wheel? We're worried about that. Thoracic injury of the chest. Where did the airbags deploy? What speed was the vehicle going? How much damage was done to the front end of the vehicle or the compartment end, the section that the patient is occupied? It's not just, oh yeah, the mechanism of injury is a fall. Great, that doesn't tell me much. How far did they fall from? What did they, part of their body did they hit first? And ultimately, did they hit more than one part of the body? Because now we're talking multi-systems trauma, and we're going to need to make sure that everything in between those areas, at the very least, is not, hasn't had injury and be suspecting of it. And also, what surface did they hit? And then, we start to add on other things of this as we get into that history taking about medications that they're taking, comorbidities, things of that nature. The primary assessment, we're going to focus on identifying and managing life threats. So the scene safety, primary assessment, it's going to be the same for every patient, right? As far as we need scene size up, we need to BSI, the scene is safe. How many patients do we have? Do we have the right resources coming? What was that mechanism? How much force was applied to the body and where? I'm considering C-spine. Do I take it now? Do I rule it out? What's going on with that? And then we get that primary assessment. We're going to get that general impression. How do they look like from the doorway when I look at them or right as I get on scene? And then we're going to need to, if there's any major bleeding, control that major bleeding, protect their airway, their breathing, their circulation. And if there's any a problem with any of those or a life threat, we need to manage it at that point before we further move on to the assessment. Some considerations for spinal immobilization is the use of backboards. So we used to backboard a patient just based off mechanism of injury alone. You were in a motor vehicle accident. You're going on a backboard. Well, I don't have any deficits. I don't have any pain anywhere here. Well, this is for your own good. Do a standing takedown. So essentially put a backboard behind them as they're standing up and then put your arms through their armpits as they're on the backboard. Have somebody else hold the board as you slide them down and then get them onto the gurney. So we're following away from that, which is a good thing, but I don't want, my concern is that people aren't backboarding or at least using spinal motion restriction on people that need to. Now, spinal motion restriction is the use of a cervical collar, and this should be done with a patient that is awake, alert, conscious, talking to you, is following the rules, because the best person to make sure that they don't have further injury will be the patient if they can keep themselves in line. So in that instance, the C-collar is more of a reminder for the patient, for everybody else, that hey, there's probably an injury here, but the patient is self-splinting, which if they are in pain, they probably will be anyways, right? They'll be self-splinting due to the pain or trying to keep it in that position, and that's just kind of a reminder. And then the full spinal immobilization use of a backboard. Backboard's more considered now of an extrication device to help get them out of the vehicle onto the gurney, or to load them into a helicopter quickly, or if they are unresponsive, so we can't do a neurological assessment, or they're under the influence of alcohol, or they have, or you're suspecting it because they do have a neurological deficit, pain, anything that you notice on the exam. So it definitely has its place, obviously, using full C-spine and a backboard. And the thing with it is we have to practice with it and be efficient, so that we're able to execute it quickly. And we'll go through and we'll show you the different steps and tricks of the trade. Big part of it is, even if you're not as familiar with it, oftentimes you'll have other EMRs that are good at doing it and practice it all the time. You have resources, fire departments on calls like this, so you can delegate that out to get them into full C-spine. You making sure that they have quality circulation, sensation, motor function in the position that you found them before you manipulate them. Sometimes you may have somebody be married to the head, so they're going to grab that. Then at that point, you'll get that baseline CSM, and then after you have them fully immobilized, as well as if any point in time during the skill you manipulate the spine in any way, you should recheck those CSMs before you move on. If you do delegate that out for somebody to put somebody on a backboard, and make sure that you come back and you check the straps to make sure that they're tight. You make sure that there's no voids. If there's voids or space in between everywhere, or any places like their knees or their shoulders, that you pad those voids. And this is especially going to be the case for patients that are elderly or have any sort of curvature of the spine. Oftentimes we're aware of scoliosis, right? The kind of S shape, the lateral curvature, but then we also have kyphosis and lordosis. So kyphosis is the hunchback. Their head's kind of down, and you see that curve of the spine as it goes up across the head, and then their head's kind of bent back down. And then lordosis is when it curves upward, and their eyes or their head's kind of bent upwards. I think of that, lordosis, right? Looking up at the Lord. So a way to kind of differentiate between those. Those patients may not be suited to be traditionally immobilized on a backboard, depending on what this is. So you may have to find other means to secure a patient and immobilize that spine. Oftentimes, kids will give us a problem just because of their different body sizes. They may not fit a C-collar, so we may take a blanket and roll it up and wrap it around the neck and secure that so that they're not able to move or manipulate the spine. That's the ultimate goal when we're trying to immobilize the spine, and understand the difference between full spinal immobilization, which is a patient on a backboard, strapped down from their chest to their toes, head blocks a place to the side, and their head taped down to the board, versus spinal motion restriction is just a simple C-collar or maybe a soft collar. Cervical collar. Once the cervical collar is on, do not remove it unless it causes problems with maintaining the airway. It's not going to be comfortable, so be aware of that when you ask the patient questions, because oftentimes you want to know, if you get that neck back in line, does that cause more pain, right? Because their spine may be displaced in a way where it would cause more damage to get them in that neutral position, and that's how you'll be aware of it, is you'll meet resistance when you try to get that head in a neutral position or in line how you normally find it, or you cause pain when you do that. But oftentimes when you put a C-collar on or have somebody on a backboard and you ask, hey, are you in more pain? They most definitely probably are going to be more uncomfortable, and maybe in significantly more pain if they have a spinal injury and there's that bruising and all that pressure is on that point. But that could be the patient that's more important with. So ultimately we won't remove the C-collar unless it's interfering with maintaining their airway. If you must remove the device, maintain manual stabilization of the cervical spine until it can be replaced. This is also true and why it's difficult if the patient's clothes aren't removed prior to be placed on a backboard and they're a multi-systems trauma and we need to get a good assessment. So if anything that we remove off the patient, then we're going to have somebody manually hold that spine or the neck in an inline position. Another consideration of having somebody or what we need to focus on is the head is going to be the last thing strapped down when we're using the skill of backboarding a patient. And then if for some reason you were having to let them off, the head strap would be the first thing to be removed. Because if you put the head strap down first and you're now working on strapping down the body and then something happens on scene, somebody shifts, somebody moves, you're on uneven ground and the board moves, well, their head's going to stay with the board in place and their body's going to move independently and you're going to cause a gross manipulation of the spine. Assessing for signs and symptoms. Ask about their chief complaint. What is bothering you the most? Confused or slurred speech, repetitive questioning, amnesia, whether it's retrograde, anterograde, response patients are indications of a head injury. In the setting of trauma, assume your patient has a head injury until your assessment proves otherwise. So that considering C-spine, as you're showing up and you're going through your assessment, realize based off the mechanism, you can take that considering C-spine and I'm going to show up and I'm going to take C-spine. Can you have somebody, okay, when we show up, the automobile accident, grab the patient, can I have you buried to the head? And now you start your line of questioning to assess the potential need for spinal immobilization as did you lose loss of consciousness? Is there, do you have any pain in your head, neck, or back? You palpating? Are you manipulating? No neurological deficits, quality CSMs. They're able to move their neck full range of motion without any neurological deficits or increased pain. Hey, then we can have that person, you can determine at that point to no longer initiate C-spine. But based off the mechanism of injury, we're not saying, hey, for sure we're going to backboard this person full C-spine, right? That's the way of the past. But we should initiate those steps based off that because it's the same idea of when you approach a motor vehicle accident, safety-wise, we oftentimes want to avoid the bumper, so we're not going to come straight on, but at a 45-degree angle at the tires there, in case the tires blow out, the bumper blows out, but we're still ahead of the patient so that we can talk to them, communicate with them, ask if they're conscious, ask them not to move their head around, ask them to respond verbally yes or no and not shake their head, because if we just approach them from the side window and we start talking to them, what's going to be their first response? They're going to turn their head to the side to look at you, right? That's a pretty natural response. And then at that point, we did exactly what we've been trying to avoid. So that considering C-spine, it's because it'll change how you approach the patient. It's not just, am I going to take C-spine precaution? I'm deciding now. When we consider C-spine, it's consider how you approach the patient. Consider what equipment you're going to take with you. Consider what you're going to have your partner do initially, right, as your resource management. So this is where these considerations come in. Unresponsive trauma patients should be assumed to have a spinal cord injury. Patients with decreased level of responsiveness should be considered to have a spinal cord injury based on their chief complaint. The fact that they're altered or they're unresponsive, right? That's a neurological deficit. That's not normal. Now, things that we can ask information to lower our index of suspicion is, a seizure patient that's unresponsive. Find out the story. That's why it's so important to get that mechanism of injury, or the nature of illness and combine it together. They had a seizure. They're laying on the ground. How'd they get on the ground? Did you witness this? Oh yeah, he said that he was starting to feel a little funny, and he sat on the ground. Probably because he had that aura, right? Maybe they have a epilepsy or a seizure condition and has had it before. That warning indicator that they're about to have a seizure, and they got into a safer place. Right now, your concerns for the spinal immobilization, they or you can kind of not initiate spinal immobilization at that time, and now you've freed up your partner to help you do other stuff to limit that scene time or to utilize them more appropriately. ABC considerations. Use the jaw thrust maneuver whenever to open up the airway. So when we talk about opening the airway originally, no suspected spinal cord injury, we use the head tilt chin lift, right? And I know in class I've talked about I kind of do the head tilt chin lift, but also just seeing how the mandible is and how the tongue is affixed to it. I also lift that mandible. I do a little bit of a jaw thrust. If we are working with a suspected or confirmed spinal cord injury, we're going to only do the jaw thrust. You keep that head in line, and it's amazing how you could open up that airway in an unresponsive patient just by lifting up that jaw and possibly getting an OPA in there to keep that, or most likely getting an OPA in there to keep that open for moving and transporting that patient. Vomiting may occur. We talked about if they're on a backboard, this needs to be a coordinated maneuver in order to get them on their side to help protect their airway. Irregular breathing may be a result from increased intracranial pressure, and we understand the time sensitivity with ICP if you see any of those indications, especially that Cushing's triad, the hypertension, bradycardia, and then irregular breathing. Oxygen is always indicated for patients with head and spinal injuries. So we talked pretty heavily about, oxygen it's not innocuous, it has an effect on the body. We like to maintain oxygen saturations above 94%, but we like to stay below 100% so we know what we're doing. But this is one of those instances where we are going to give them high levels of oxygen. One, they could be having some internal bleeding, so we don't know about the status of their circulating hemoglobin, and also just the need for the oxygenation of the brain. We have a big fear of that secondary injury of hypoxia. So we want to give them a hyperoxygenated environment. If they're ventilating on their own, put a non-rebreather on at least 10 liters per minute, a high flow oxygen, or utilize a BVM if they have a ventilatory problem or they're breathing too fast and you can't control that with coaching them because they're semi-conscious or not responding to you. A pulse that is too slow can indicate a serious condition. One note that I don't know if we've talked too much about is other things that may cause that slow bradycardic heart rate. It could be medical conditions. You can ask about that if there's family members around, or also, an athlete, somebody that's very much in shape, may have a slow heart rate just naturally. But in the instance of, see how they're responding, how they're acting, you would expect this heart rate to be increased. So the slow heart rate is an ominous sign and part of the Cushing's triad. A single episode of hypoperfusion can lead to significant brain damage and even death. So what is hypoperfusion? Right, hypoperfusion, we also kind of put that with shock. And when we're thinking of hypoperfusion, if a patient is hypoperfused, they're not getting blood flow to that tissue, so they're not getting oxygenation to that tissue, so they are hypoxic as well as being hypoperfused. Assess for signs and symptoms of shock. Make sure you control that any major bleeding. That's kind of the free floating. When we're going through our primary assessment, we're doing the general impression, level of responsiveness, airway, breathing, circulation. Well, when do we control major bleeding? As soon as you recognize it. That's the time that you have to get on it. And again, this is something that we can do utilizing our teammates and directing them, right? You put pressure on that and put direct pressure. Remember, we're not just kind of lightly sitting it there. Direct pressure, oftentimes you're going to have to put some significant force to try to stop that bleeding. And if it's not stopping and you're able to apply a tourniquet to an extremity, apply that tourniquet. I know we talk about the bigger concern is going to be generally the traumatic brain injury, like if we see that scalp laceration, which is true. When we talk about major bleeding, we're worried about arterial bleeding, we're worried about venous bleeding, if it's been going unchecked for a while, and even capillary bleeding, especially if they're on blood thinning medication, then that starts to be more of a concern. But that is something that you can be treating that bleeding at the same time that you're going through that primary assessment. But if it's just you and you had one more step, as soon as you recognize that major bleeding, you got to stop that bleeding. Because if they lose all that blood volume, then we're not going to be able to perfuse them appropriately, and they're going to be hypoperfused. Manner of transport. Patients with impaired airways, open head wounds, or abnormal vital signs may need to be rapidly extricated from a motor vehicle and transported. This is what we call an emergent move, right? It's not always going to be because of fire, explosion. It could be, hey, they don't have an airway. I can't, based on how they're positioned, I cannot manipulate in order to open up their airway. We need to rapidly extricate them. It doesn't mean that we throw all logic out the window of trying to keep that spine in line, but it may be a quicker move than what you intended. And be sure if you have to execute a move like this that you pass it along in your report and that you document it, because that will protect you if later on they find that there was a spinal cord injury, and to kind of show why you did. You were, again, the do no harm. It doesn't mean like, oh, don't do anything. You're trying to do what's best for the patient. Lights and sirens can lead to patient anxiety, and just kind of, they've done a lot of studies. Going code 3 does not save you a lot of time, right? There's very few instances in my career where we've had to go code 3 legitimately. I'm not saying that we've never done it, right? We've done it quite a few times, but most of the time, just driving, especially a rural area that we have, it's not going to buy you a whole lot. Could stress the patient out, could stress you out, right? That noise, that elevation of the heart rate just due to that, and the safety concern of driving. People do weird stuff when they see those lights happen, so just be cognizant of that. As always, we're going to investigate that chief complaint. What is bothering them the most? But at the same time, understand that might not be what is, they may be complaining of pain in their right leg from a femur fracture, but then you also notice that they have unequal pupils, they're starting to look a little confused, and we're more concerned about the traumatic brain injury, so there's kind of that balance. We're going to obtain medical history and be alert for injury-specific signs and symptoms, as well as those pertinent negatives, right? Did you lose consciousness? Were you wearing your seatbelt? The damage pattern of the vehicle. Kind of, I know, go back to the motor vehicle accident, but those are where a lot of our trauma injuries are, very dynamic scenes, and it's very important that we soak up and we pick up all of these little nuggets when we're on scene there, because once we leave, the doctors are basing much of them understanding the mechanism of injury based off of what we tell them, what we pass along. And even if you're not a transporting EMT, if you can put a synopsis of what's going on with the patient, but what the mechanism of injury are, pertinent negatives, damage patterns, things like that, and give them to me up front, and you have your patient packaged, you know what we're doing? We're loading and going. We're out of here. If you're not able to provide that, then it may just be seconds or minutes, but I as a transporting provider, have to make sure that I understand this information. So that's another way you can be a positive link in this chain of survival. If the patient is not responsive, try to obtain history from other sources, right? Did anybody see this? Bystanders, and understanding how to talk with and get bystanders involved is something that kind of comes. But the kind of good rule of thumb is you want them in arm's reach or a distance. That you don't want them to get in the way so that you can do what you have to do. But if you have questions, ask them, right? And you don't want them to walk off, because you may think of something a little bit later as you further your assessment and have them nearby so they can provide some info. On your secondary assessment, instruct the patient to keep still and not to move their head or neck. The physical exam may be a systematic head to toe. That's going to be for your multi-systems trauma. It might just be the full body scan. That could be more for the patient that's not complaining of any trauma injury, but they can't, they have dementia, they're elderly, they're under the essentially intoxicated, and you can't really they're a poor historian is a good way to put it. And so we're at the very least going to do a full body scan and make sure we're not missing anything. Or it could just be the systematic assessment that focuses on that isolated body part, right? Their ankle, because they stepped off the curve and they have pain in their ankle and heard a pop and they didn't lose consciousness, right? No head, neck, or back pain. pertinent negatives that I'm describing, but those are definitely going to need to be in your report and in your thought process. If you're saying, oh, this is an isolated injury, you better be able to rule out all those pertinent negatives. Decreased level of consciousness is the most reliable sign of a head injury, and this is why when we're assessing and then reassessing, that's why I say there's no bad questions. Keep talking to them, whatever they want to talk about. Now, the one time in assessment where we kind of lay off this a little bit or be understandable is if they are having difficulty breathing, or they're focusing on their breathing, but otherwise we want to know about their mentation. First sign of the change is going to be that change in their level of consciousness, which can be difficult if you don't know the patient. And then if you have a family member or bystander, perfect question to ask: is this normal for them? Do they appear normal? Do they appear not normal in any way? Specifically, what do you see that's abnormal? Look for any blood or CSF. Assess pupil size and reaction to light, and continue to monitor those pupils. You check them initially, but then that's part of the reassessment. There's a lot more to reassessment than just getting another set of vital signs, right? We need to check their general impression, their responsiveness. For the suspected brain injury, we're going to reevaluate their pupillary reaction, and as well as getting that full set of vitals. Neurological exam. Perform baseline assessment using the Glasgow Coma Scale. You guys are responsible to use the Glasgow Coma Scale. National Registry will have you calculate a Glasgow Coma Scale, and this can be a difficult thing to wrap your brain around. I more want you to feel comfortable that if you have it, because especially as we're becoming new at this, we are going to use resource guides and a Glasgow Coma Scale to have that is totally acceptable in my opinion, right? It's a little bit of cognitive offloading, so you can focus on big picture and just pull out your GCS guide and calculate it really quickly. You bring a trauma patient into the hospital, you provide report to the transporting ambulance. We're going to want to know first thing, what's their GCS, right? It would behoove you if, as you're using the resource, instead of just printing one out, is write it on your notebook, write the GCS out. And that way you get practice of writing it, and that action of writing it out, it will cement it in your brain much better. And then be sure that you record any changes in their level of consciousness. If they fluctuate, if they deteriorate, that's very important too, right? They're a GCS of 9 now, but they were a GCS of 14. That's important. Or maybe they're a GCS of 14, but when you arrived, they're a GCS of 3, right? They were unresponsive, but now they're back to it. So, the major changes is important, as well as just the number that they are now. So here is the Glasgow Coma Scale. And when you look at the eye opening, it's the same as AVPU. Alert is the same as spontaneous. Responsive to speech is verbal. And the point here with the spontaneous and the response to speech, it's their best response. You may show up and their eyes are closed. It could be because you're outside and the sun's bright. But once you start trying to assess them and communicate with them, what is their best eye opening? Are they able to hold their attention on you with their eyes? Are they alert? Or do they get drowsy and they keep closing their eyes? Response to pain. Remember, trapezius pinch is a good way, as long as there's no injury to the clavicle or that area. Doing a sternum rub is an effective way, but at the same time, now when you assess the patient for pain and they say they have chest pain, was that from you or was that something that was there previous? If they were wearing a seatbelt in an automobile accident, you're probably not going to want to do a sternum rub on them. And then we go into the best verbal response. This is maxes out at 5. Are they oriented? That's person, place, time, and event. The kind of caveat with this is you're trying to, the Glasgow Coma Scale for best verbal response, a 5 it's oriented, but it's also their baseline. So if they never know what year it is and they don't know what year it is, then I would still put their GCS for best verbal response as a 5, right? If there's no other, signs of confusion, they're to their baseline, right? Maybe they have dementia or something else that's going on. If they're confused in their conversation, then this is a 4. Inappropriate words, a 3. And this really gets into with the stroke patient, right? It's not just, because are they confused or are they using inappropriate words? The inappropriate words they're not saying what they intend to say, or they are very much kind of speaking this weird kind of crosstalk. It's not just that they're, confused, but their sentence structure, everything is really off, right? And so that's significant for some kind of issue with the something going on with their brain. Incomprehensible sounds, maybe just groaning when you do a sternum rub. If they just groan when you do a sternum rub and kind of shrug their shoulders forwards, then that means that they're responsive to pain, so that they get a 2 for the eye opening. Incomprehensible sounds, so they get a 2 for the best verbal response. And then if we look at best motor response, are they withdrawing from pain? Are they localizing pain? Usually when I think they're kind of going towards it, they're localizing it, right? And so I usually put that at a 5. So that's 2, 2, and 5. That's a GCS of 9. Now you could see how there could be, someone might put that as, they're withdrawing from the pain. So that's a GCS of 8. So there is some sort of, it's slightly subjective, right? It's very much subjective depending on who is performing the Glasgow Coma Scale. So we're trying to keep in our mind when we give this GCS is we're trying to accurately describe what we're seeing with the patient, right? What we're seeing. So be confident with that, but also explain, because I could say a GCS of 9, and that could essentially be somebody that opens their eyes spontaneously, but they are they're nonverbal, they're not talking to you, and they're able to localize pain. right? That's a very different patient than a patient that responds to pain, incomprehensible sounds, and localizes pain. So we just have to make sure that when we're passing this information along, that we are quantifying or identifying what we're giving those numerical numbers to. I've seen this a few different ways. I've seen people put, kind of a GCS of 9, and they'll put, 225. Good. If I'm real familiar with the Glasgow Coma scale, then I can calculate that out and figure it out. What I like to do is just simply either state it or how I write it. Right? They're GCS of 9. They responded to pain with incomprehensible sounds, but they localized, right? Or kind of more cleanly, they gave incomprehensible sounds localized in a response to pain. However you want to put it, but that way it's really clearly put forward, right? So don't be too intimidated by the Glasgow Coma scale. Just try to utilize it, think about it. And as we're kind of looking at this chart, the best way that I've found to wrap my head around it and to be able to add it up in my head without, having to use a reference guide is, AVPU is pretty easy, going from 4 to 1. Best verbal response, 5 to 1 is pretty easy, understanding each one of those. Now when we get to best motor response, for some reason having those 6, different points, it gets it really jumbled in my head. But most patients are going to fall into one of two criteria. Either they're going to be on the level of obeys command, localizes pain, or withdraws from pain, right? So in that way you can go from 654, right? Pretty easy. And then your other patient, that serious critical patient that you see posturing, you're going to see posturing for the first time, your brain's just going to freeze up. And so, understand that you'll go from nothing up to the worst would be Deceribit posturing gets a 2, Decorticate gets a 3. For some reason that works well in my brain, but just find what works for you in practice, because it is very important. They're going to want to know, we want to know what their GCS is. Spine examination. Inspect the decap ETLS and also check for CSMs in all extremities. If you show up and the patient has their shoes on and you give me their CSMs, or you say that they have quality CSMs, or they have no neurodeficits, then I'm going to think, hey, you didn't do that appropriately, because how did you appropriately evaluate their lower extremities? Pain or tenderness, warning sign. Listen to there's potential injury underlining right there. Other signs and symptoms could be deformity, numbness, weakness, tingling of the extremity, and soft tissue injury in the spinal region. So we're going to actually palpate the spine. We're going to walk it down each vertebrae. We're looking for step off or any deformity or increased pain on palpation. Reassessment. Repeat that primary assessment. Reassess the vital signs and the chief complaint. What is bothering them the most? Okay, after you have essentially evaluated them and done any intervention, maybe just treating for shock, applied oxygen, or put them in full C-spine, reevaluate. So your neck was bothering you, how was this a 10 out of 10? How is your pain now, right? Reevaluate after that. And any intervention that you do, they were short of breath, you put them on oxygen, how is your breathing now, right? And try to be systematic when you do things so that you know what caused the change, right? If you change too many things, give too many interventions without reassessing, then you don't know what caused that difference, right? Oh, I'm feeling lightheaded. Okay, then you lay them on the ground, you put them on high flow oxygen, and then now you ask, are you still feeling lightheaded? Oh, no, I feel much better now. Okay, well, what was that? Was that the change in position that did that? Or was that the oxygenation that changed that lightheadedness? So again, as we want to treat and we want to get them better, obviously, quickly, but we want to know what one of our treatments had what effect on them. It's very important for their continuity of care, or continuing to get them to that definitive care in the next link of the chain. These injuries can suddenly affect the respiratory, circulatory, and nervous system. Reassess at least every 5 minutes. I do get this a lot when we do trauma assessments for our testing, and we'll have a patient that's unresponsive
It's a GCS of 3, right? Not responsive. Their eyes don't open. They're not responsive to verbal. That they have no motor movement whatsoever. But their blood pressure 120/80. Respirations are 12. Heart rate is 90. And then they're like, oh, they're stable. I'm gonna reassess them every 15 minutes. Like, what? They're stable? They're unconscious, right? Altered level of consciousness, that on its own, especially when you take into consideration the mechanism, they are a very, very critical patient, and we're going to reassess them every 5 minutes. Another thing I see on that note, too, is so how often are you going to reassess this patient? Every 2 minutes, right? They'll say something like that. It's like, well, how is that even possible, right? It takes about 5 minutes to go through and to be reassessing this. So those try to stick with those numbers and keep it clear. Also for testing purposes and NREMT. For a stable patient, it's 15 minutes, unstable 5. Now, I do believe that most patients could lie in that 10-minute kind of marker, especially the initial, first half hour that you're with them, if you're with them for an extended period of time. Could be just based off the mechanism. Hey, everything seems stable, but based off that mechanism, there could be an underlying injury that I don't see, so I'm going to keep an eye on them for those 10 minutes in case there's some trending in their vitals over time. I'll see it quicker. It's going to be very difficult. How long will it take you to see the widening pulse pressures, or that's the widening between the systolic and diastolic, if you're only checking their vital signs every 15 minutes, right? Essentially, in my opinion, it could take you about 45 minutes before you see a change if that's what you're sticking to. Whereas if you're checking it every 5 minutes, you may discover that in 15 minutes or 20 minutes. So there's a big difference there as far as trending vitals over time. And that gives into the compare baseline vitals with repeated vitals. That trending over time is what we're concerned about. You will notice deterioration in consciousness, patient's awareness of time, place, and person to self in that order. So when we think about orientation, that's usually how a patient starts to initially they'll forget kind of the event, and then their time, and then place, and then self. Right? The one thing they don't really talk about in there is the event. But we do orientated times 4, person, or person, place, time, and event, and then backwards is the last thing that they should forget would be who they are as a person. Lastly, in our communication documentation, when we're providing a report, we want to lead with that GCS, with that mechanism of injury, with pertinent negatives. Are they in full C-spine or just spinal motion restriction, or it hasn't been taken? Those very important information. They don't want to know the pulse rate, blood pressure, SpO2 that you took. They don't want to know specifically what those numbers were. If for every time that you took them while you were with that patient. They need to know the high points. Basically, what you got to realize when you're giving a report is, what does this report mean to the person that I'm giving it to? It's kind of like a guide for them to make their decisions. So if you understand that, that'll help you out. If you're giving a report to the transferring ambulance, they're trying to make decisions on destination, on do I need a helicopter, do I need other resources, what equipment should I bring on scene, do I need to give you any further guidance, right? Are you handling it appropriately on scene? That's the type of information, and kind of the same, but in a different light for the hospital. They're going to make a decision on, does this meet trauma criteria? And it might not for us. We talked about the trauma triage scheme, and if they meet that, then we're going to also open up with that as soon as possible while on scene, maybe still packaging them. We'll hail Banner Lassen, SEMSA Medic 1, trauma activation. For a 64-year-old male that fell off the second story of a building, GCS of 3, and then you're going to go in to provide that more information. You're going to give vital signs of things have how they changed or things that were vastly different, or just the updated, the last set of vitals. So we'll practice on that communication and documentation and how you provide these reports. It is kind of an art form, and that's something that when you get into EMS and you start training, that they will guide you on how to give reports, because some hospitals are different as well. Seneca Hospital, there's a lot more information that they want on that radio report, whereas Banner, that they're happy with just enough information so that they can make their decisions, and you can give them that full report on arrival. Remember, document vitals every 5 minutes on an unstable, 15 on a stable patient. 3 general principles: secure and protect that airway, control major bleeding, and help maintain adequate circulation to maintain that cerebral perfusion, and assess and continuously monitor their level of responsiveness. Level of responsiveness and their mentation, their thought process is going to be the first sign with a traumatic brain injury that's something that they're deteriorating. To manage the airway, once it's open, maintain the head and cervical spine in a neutral inline position until you have that C-collar in place and secured the patient to the backboard, head taped to the backboard, right? That whole time you'll have somebody be married to the head. Even though they have a cervical collar on, you still have somebody there until they're fully in spinal immobilization. We're going to remove any foreign bodies, secretion, vomitus. Remember, gravity helps us out the best for that gross amounts, and I mean gross is large amounts of vomit or blood or secretions in that airway to let gravity help turn them on their side, and then use the Yonker tip rigid catheter to get deep into that oropharynx at the base there in order to clear that. The advantage of that is the depth that it's able to go. It's not very good at getting large amounts of vomit out. Give supplemental oxygen to any patient with a suspected head injury. Showing up somebody holding the head in a neutral position, and this person placing the C-collar on. Now, she's got one knee down. It looks like she's in a fairly comfortable position. If you ever are being married to the head, as you take control and put that head in an inline position, you need to make sure that you're giving yourself the best chance. If you're going to be there a while, sometimes you may want to try to have your elbows actually on the ground and kind of base your fingers on the ground, and then hold the head so that you're not floating in space, trying to just maintain it, because you may be held in that position for quite a long time. And the other thing to recognize too, considering C-spine, what if there's 6 patients and there's you and your partner? You can't walk up to the first patient, I suspect a spinal injury, have you be married to the head, because if they walk away from that, now you, from being married to the head and there's an injury, you essentially abandoned that patient. Now, if you don't essentially marry to the head or get that head in inline position and maintain C-spine, initially you're not going to be held accountable, right? That's just simple triage. You're trying to do the best with the resources that you have. So make sure that you go through and triage everybody first before you start allocating resources if you have limited resource and a lot of patients. Begin CPR if the patient is in cardiac arrest. Control bleeding from a scalp laceration by applying direct pressure over the wound, because we're not able to tourniquet, right? Anything on the core. Shock is usually the result of hypovolemia. So hypovolemia is blood loss, generally when we're thinking of a traumatic injury. And the problem with hypovolemia is, even as an ALS provider, I can give normal saline, right? I can put normal saline in the system, but if they're bleeding out and we haven't stopped that hole, all I'm going to do is, instead of them bleeding out red, they're going to bleed out pink, basically implying I'm just diluting out their blood. Normal saline doesn't have any hemoglobin in it, no red blood cells, so it has no oxygen carrying capacity. So I want to maintain the blood that they have within them. That's why we establish large bore IVs in case they need fluid resuscitation, but we're generally happy with a lower blood pressure. And I mean happy with, we don't intervene and start giving them fluids even if their systolic blood pressure is 90, right? We are, the permissive hypotension is what they call it. We're happy with that lower blood pressure as long as they're still, perfusing their kidneys, have a good map, they're still mentating okay, because of the problems that it can cause just by fluid overloading them. Then we get into Cushing's triad. I like to think of this as kind of the reverse of shock, compensated shock as far as your blood pressure and your heart rate. So in shock, we see essentially the blood pressure will stay the same, and they become tachycardic, and then we'll start to see that blood pressure drop. In Cushing's triad, we have hypertension and bradycardia, high blood pressure, low heart rate, and then we'll have that irregular respirations, the Cheyne-Stokes, right, is the increasing respiratory rate and then decreasing, and then apnea. And then the buyout respirations, kind of gasping, and then that same period of apnea. Apnea meaning without breathing, right? So both of those irregular respiration patterns, especially when combined with hypertension, bradycardia, is Cushing's triad, going to be highly indicative of the head injury, traumatic brain injury. Perform controlled hyperventilation of your patient via positive pressure ventilation at a rate of 20 breaths a minute. So basically, if we increase the respiratory rate, we may be able to help combat that intracranial pressure in the moment. So I don't want you to see 20 and then actually be performing 30. So it's just a slight increase in the rate of ventilations if you're ventilating the patient with a BVM. So we're going to follow standard precautions, maintain the patient's airway while keeping the spine in proper position, manage that airway, no blunt force trauma to the face, could take an NPA if they have a gag reflex. Otherwise, an OPA would be the gold standard for the BLS airway. So be careful that you don't do further damage if there are bone fragments involved as you're packaging the patient, trying to keep it clean. Never force the head in a neutral inline position. If you meet resistance or it causes pain, then you're going to want to immobilize it in that place that it's at and stabilize them in that current position. This shows utilizing the jaw thrust maneuver. You see that the head still maintains that neutral inline position, and you see the mandible just displaced anteriorly. And what we're not seeing in the back, in the oropharynx there, is that tongue now is separating and keeping that airway. Cervical collars provide preliminary partial support. Should be applied to every patient who has a possible spinal injury. If they are ambulating around and they're conscious and alert and they're following your directions, you can have them maintain their head in line and then also put that C-collar on. The rigid collar must be the correct size. There is a sizing guide on there, and you'll see the little lines on it, and then we essentially can use our hand and our fingers. The standard patient is going to be the no neck and a 5-finger place, and we are measuring it on the patient first between where the clavicle is to the jaw line right there, and then we're going to then move that over to the C-collar and make sure it's in the correct position and locked in place. Sitting patients, we use a short backboard, a Kedrick extrication device to secure the patient in the sitting position, and we want to make sure that we lift the patient, not the KED, because it's very easy to get the head strapped down tight, difficult to get the leg strap in. So as soon as if you were to lift them from the KED device, then the patient will slide down and their head is going to be secured very well to the device, and so you're going to manipulate that neck. So always, use a seat carry, create a seat with somebody in order to lift that patient safely, and don't lift the device. Once you have them out of the vehicle, remember it's extrication device used to move them from a sitting position, and you place them on a backboard, you're going to need to undo the leg straps and then secure them to the backboard. Limiting these are probably should be used a lot more often than they are, but people aren't comfortable with them, so they don't. So it may take a little bit longer to utilize. Standing patients, like we talked about before, the standing takedown is falling out of favor. Our local protocols for NorCal actually specifically state to not do a standing takedown. So I won't spend a whole lot of time, but essentially you're going to, if you were in an area that still would like you to do it, you're going to immobilize the patient onto a backboard by holding their head in line, apply a C-collar, put the backboard directly behind the patient, and have somebody stabilizing the head. It's going to take multiple personnel to do it appropriately and safely. So having somebody maintain married to the head as another person slowly slides the patient down onto the backboard, being sure to foot the bottom of the backboard so that it doesn't move until you get them onto the ground. And then you're going to package them the same way that you would do with a supine patient onto a backboard. Spinal immobilization devices assume the presence of spinal injury in all patients who have sustained head injury, use manual inline stabilization of the cervical collar and along backboard. And so all patients that we suspect a spinal injury, regardless or potential for, should have a C-collar in place. Now, whether they should be in full spinal immobilization could definitely, if they have any deficits, distracting injuries, unconscious, under affected by drugs, altered in any way, or there's a language barrier and you can't do a full assessment, neurological and physical assessment, you're going to put them in full C-spine on a backboard. Here is the Kendrick extrication device used to immobilize a patient to protect them from further spinal injuries when they're in a seated position. You can see that the straps are color coded, at least the buckles are. Now, you may hear some different acronyms to remember this. My Baby Looks Hot Tonight is one that I remembered and I taught for a long time. So my being middle, baby bottom, looks legs, H for head, T for top. Now, the problem with that is when I review the National Registry order of applying the straps, it's actually different. So I'm kind of modifying that. You should put it, try to remember it as My Baby Tastes Like Honey. So My Baby Tastes Like Honey would be middle, bottom, top, legs, head. So another issue with that I have with the KED, with people that aren't very familiar with them, is you see these black loops kind of medial just above those white legs buckles right there. They look a lot like handles, right? And so I talked before about how if you lift the KED, the device, and not the patient, then they're going to sag down in those leg loops, but their head's going to be really tight against the top because it's easy to get that head strap tight, and then you're going to manipulate that spine much more than you want. So make sure that nobody uses those as a handle. Stop that move, re-educate them, and get them to do it appropriately. I've had to do this multiple times on a call before because they just look so enticing, like that they're handles, but they are not handles. Another part that I'll try to demonstrate for you guys in a later video is how you get that leg strap. You're going to want to get, that's going to be your biggest problem area with getting this device strapped to them appropriately, because you're going to want to have it nice and tight and against their back and to keep it in line. And like I said, if you the place that they're going to sag is in those leg straps, so you got to kind of floss it through and make sure that it gets real close into their groin area, whether female or male, but especially with male, you may have have them help assist you so that they feel more comfortable, so that you can get a nice that strap nice and tight up into their groin without causing them this discomfort against their genitalia, so that you're able to get that as tight as possible. Here's a long backboard. Been used in design for a long time, probably since the Civil War, when they used doors or boards to pull people off of the battlefield in order to hack off a limb and attempt to save their life. Not much has changed in their design, kind of being facetious, but there's handholds. Some of them are made out of different material depending on how they're utilized, but essentially all it is a long, rigid piece of material, a board that you're able to secure the patient onto. You see those yellow blocks up towards the top there. Those are head blocks, is what I commonly refer to them as, and those will place right against the patient, the head on both sides, and then tape that down after you have those straps attached. Helmet removal. A helmet that fits well prevents the patient's head from moving and should be left on, provided that there's no impending or airway breathing problem. It does not interfere with assessment treatment of the airway. You can properly immobilize the spine. One instance where you have to, if you show up, especially depending on what type of helmet may be different. Like if it's a football helmet and the shoulder pads stay on, then you most likely can just take off the face mask, unscrew it, so that you're able to protect their airway, better assess them, and that helmet and the shoulder pads may do well to kind of help splint, and you can secure them that way. Now, if the shoulder pads have already been removed, you're going to have to take off that helmet, because now there's going to be a big void under their shoulders with the size of the helmet, and it's not going to keep that head in a neutral position. Remove a helmet if it's a full face helmet. Now we're talking more like motorcycle helmets. It makes assessing and managing the airway problem difficult. If it prevents you from properly immobilizing the spine, we talked about that with a football helmet and shoulder pads. Or if it allows for excessive head movement inside the helmet, or if the patient's in cardiac arrest. The preferred method is removing the helmet should always be at least a two-person job. That way you can have somebody not take the normal married to the head from the top position, but instead they come from underneath the side where the ears are, and marry the head from that direction, from an inferior aspect, and the person is able to then lift the sides of the helmet and remove it up and anterior as they kind of lift and remove it, and then the first the provider is going to maintain that inline stabilization.